we're going to move on, and now we're going to address post-transplant. So we're going to ask Rachna Kataria to come up and talk about role of under-recognized pulmonary hypertension in PGD post-OHT.
All right, thank you. Thank you, Marwan, for the invitation to present to this esteemed panel. We're going to talk about this conundrum of under-recognized pulmonary hypertension, which we alluded to in the previous session, as it pertains to transplant patients by diving into a case. 50-year-old male, blood group O, with restrictive cardiomyopathy in the setting of AL amyloidosis. He's referred to a heart transplant center for worsening NYHA symptoms, listed UNO status 4, started on some milrinone, 0.375 of milrinone. And his right heart cath on milrinone at the time shows a right atrial pressure of 11, PA pressure of 48, 28, 35, wedge of 28. His index by thermodilution is 1.8, TPG of 7, PVR of 2. 7 years go by on the wait list with an annual right heart cath evaluation, and he has progressively worsening symptoms. So he comes back for his year 7 right heart cath. This time around, his pressures are right atrial 12, PA 57, 32 over 40, wedge of 32, index of 1.7, TPG is 8, PVR is 2.1. He's admitted for optimization. His PVR during the hospitalization ranges anywhere from 2 to 4.5, so obviously some reactive pH there. He's intolerant of higher doses of milrinone in the setting of increased NSVT. So a UNO status exception is submitted. He undergoes DCD heart transplant about a month later. His hemos immediately prior to the transplant show a TPG of 11, PVR of 2.8. His PA pressures are 40 over 28, mean of 32. His post-op TE in the OR is now showing moderate severe RV dysfunction. His LVEF is about 30-35%. He has mild, moderate MR, some TR, AI, and so he comes out of the OR on central ECMO with a balloon pump. Post-op day 3, he goes back to the OR for ECMO decannulation. Post-op day 4 to 6, he's now in uric, so his CVVH started. He's having frequent episodes of AFib, SVT. Post-op day 7 to 9, his mixed venous is dropping, his PA pressures are increasing, despite him being on high doses of milrinone, epi, dobutamine, Velitri, you name it. Post-op day 9, we have a mixed venous oxygen of 37%. We're now starting to see a wedge that's 15, mean PA pressure that's 31. So we have a measured TPG of 16 and a PVR of 4.4. We increase his milrinone to 0.5. We start some inhaled nitric oxide. And a TE is done at bedside, and it's really hard to even get your right ventricle in that picture. It's just dilated, right? It's dilated. The function is severely decreased. So he goes back to the OR, this time comes out with peripheral ECMO, is on ECMO for the next 12 days, goes back to the OR post-op day 21, ECMO bridge trial in the OR, he's decannulated, but once he comes back to the ICU, again, almost immediate RV failure. For the next few days, we try with medications to support him, fail to do so, he goes back to the OR for an RVAD implant. At this point is now on RVAD for 3 months with a really slow wean. Ultimately ends up with a prolonged hospitalization with complications including AKI, vascular complications, delayed rehab, and just a really long hospital course, not something you want for your patients. So diving into PGD, what is PGD? Up until 2004, we did not have a definition, and so the incidence of PGD ranged anywhere from 2.8% to 27%, depending on which center you look at. 2004, we had the ISHLT consensus conference on PGD, where graft dysfunction was classified into primary or secondary if you can identify a cause for dysfunction, such as hyperacute rejection, pulmonary hypertension, surgical complication, etc. And then PGD would have to be diagnosed within the first 24 hours of the transplant surgery, and then would further be classified into PGD LV or RV, which then can be classified based on severity into mild, moderate, or severe. The consensus conference also identified some traditional risk factors for PGD based on donor risk factors, recipient risk factors, which mentions elevated PVR. We talked about PVR in the last session, and then surgical or procedural risk factors for PGD. So pulmonary hypertension in advanced heart failure, it's quite prevalent. Depending on the data you look at, in HFrEF, the prevalence could range from 60 to 80%, and HFpEF 50 to 65%. And as heart failure progresses from stage A to D, what we see is that passive increase in PA pressures as a result of acute elevations in left atrial pressure will then progress to reactive increase or elevations, which are associated with increases in PVR, TPG, DPG. This is from chronic left atrial pressure elevations, and then ultimately with vascular remodeling, you could develop fixed pH. So really, patients could have both reactive and fixed components, and it's important to parse those out with vasodilator testing. Because if not, then your unbuffered RV that's now exposed to these high pulmonary pressures will fail, as we just saw. Various hemodynamic parameters of pH have been identified or talked about in literature. This is a study by Dr. Butler and colleagues from 2000s where PA systolic pressure of over 50 performed better than a PVR of less than 2.5, and the combination of PA systolic over 50 and TPG over 60 did best. Patients who even have reversible pH, if you will still have a component of fixed pulmonary hypertension, and their numbers, even after reversal, tend to be higher than patients who do not have pH. Then there's the conundrum of institutional protocols that vary. Thresholds are different for UNOS listing. And as an example, at the center that was just referred to, PA systolic of over 50, TPG of over 15, or a PVR of greater than 3 is what leads to vasodilator testing in order to show reversibility in those patients. Limitations of PVR were discussed in the previous session, but really it depends on flow. So for the larger patients, we may have a falsely lower PVR. MR may cause your wedge to be falsely elevated and you to have lower PVR. And then again, as we talked about in the last session, it's not really a measure of compliance of the system. Many hospitalized patients will have continuous hemodynamic monitoring, but not all. And also, we're seeing a lot more patients with temporary MCS unloading, but we're not seeing enough patients on VADs that are being bridged to transplant. So I think that's another issue that we've run into since the allocation changed in 2018. So the gaps that remain are, again, the change in definition of pH that needs to be taken into consideration when standardizing pH stratification as far as our transplant patients go, need for a consensus on thresholds for listing. The cadence of invasive hemodynamic surveillance varies, and it needs to be tailored to the specific patient. And then again, I think we need to better define the role of temporary MCS, such as ECMO or RVADs, in supporting these patients. So in summary, post-op a PGD is associated with dismal outcomes, and under-recognized pH is definitely one of the risk factors. pH is highly prevalent in heart failure end stage, and so it's important to know to look for it. It's important to distinguish reactive or combined pre- and post-capillary pH from fixed pH, because it's really that reversible or reactive component that's modifiable. And early recognition of PGD, obviously, so that we can support our patients in a timely fashion. Thank you.
Thank you very much. That was great. I was going to ask my co-moderator in a high volume center what your approach is, and then maybe we can ask the rest of the panelists.
So I have to say that, Rachna, I was looking at the case and I said, wow, this is a case that we were not so concerned about this PVR. The TPG, as you said, was not so high. Everything was not leading to this case. So I do think when we speak about PGD, we need to remember that there is more, exactly as you saw in the slide from Kabashigawa, more things that can contribute, and not only this pulmonary hypertension. I'm not so sure that the pulmonary hypertension by itself is the main cause of this RV failure. Our approach is a little bit more, let's say we encounter PGD, we will put the ECMO in. Usually our prefer is peripheral ECMO and not central ECMO from the beginning. We usually let the situation chill down for 48, 72 hours. And then we're trying to do the wean and take those ECMO out. I have to say that approach with in regard to the nitric oxide is a very aggressive. I think Evgeny, you published about the importance of nitric oxide in other settings, but we are very aggressive with nitric oxide utilization to prevent, specifically here that you saw biventricular failure or not only left ventricular failure, and you think about preservation injury that also contribute to this specific encounter. So again, PGD is a big issue. I think pulmonary hypertension is one of them, but actually I will push us now, and I'm interested in panel, because we lately changed our definition. So in the beginning, it was PVR as 3, as mentioned here, with the TPG of 15. And then we moved to PVR of 3.5. And then we're doing all those extreme testing that including also NIPRI testing and all those testing in the cath lab. So in reality, we actually transplant people with PVR of 4.5 or something like that. And again, by definition, the cutoff is 3.5, Phyllis. But I can say that I know that there are groups, and I'm interested because they're here in the audience, that lately completely took away PVR and just willing to deal with it. They just know that there are going to be some challenges.
Panel?
So one of the points that I would like to highlight in this case is really the when you weaned your mechanical support, initially everything went well for a couple of minutes when you do it, and then after a couple of hours, the situation totally went wrong. And I think that even more for right ventricle than for left ventricle, the third dimension, which is time, is a very important aspect, because often the ventricle is able to cope with an increased afterload for a couple of minutes when you do your first test, but then with time you see this ventricle decompensating, and this is a very complicated aspect to deal with, especially when you are trying to predict the winnability of your patient. And of course here it's more for the first talks than for these talks here, but I think that's a very important aspect also to take into account, which is we are able to do assessment on a given period of time, but we are not really able to understand how this ventricle will tolerate this for a longer period of time. That's just the time we are looking at.
Any other comments?
Mark.
Go ahead.
Well, and just real quickly, I agree with everything you said here, because more and more of these patients have significantly elevated pulmonary pressures than we used to deal with. And it turns out most of them you get through. And the issue, though, is in the post-transplant period, number one is prevention. So anything you can do preoperatively to at least demonstrate that there is reversibility. So as long as it could go from 4 to 2, then your approach is going to be different than if it goes from 4 to 3 or if it doesn't change. But somewhere, so we put every patient on inhaled nitric oxide from the word go, as well as a Primacor, Milrinone. Because once you get into that mode, it's very hard to get out of. And then my other suggestion, I agree, is because in those patients that are really challenging, it generally doesn't go away in 2 or 4 days. And either sit tight on ECMO, don't be in a rush, or use a Protect Duo or something similar. So you can still get them extubated, even in the ambulatory. And they can be fine for weeks, right? Because we have lung patients waiting for lung transplant, right, on ECMO for weeks, and Protect Duos. So what's the rush? Because if you terminate it too soon, the cycle starts and you may not get out of it again.
David, did you have a comment?
Yeah, just quickly, I would say that this case, I think, is an interesting case which highlights the concept of situational hemodynamics, which is to say that, in fact, this is never perfect when, all of the things that we actually learned about Starling curves, they never had anybody post-transplant, they didn't have devices in, et cetera, et cetera. And, when we use PVR, we're making an assumption typically about cardiac output, whether it's from thermal, we're not putting hoods on anybody. So I can make anybody's PVR better by starting them on epi. So who cares? And then in terms of transpulmonary gradient, you could make an argument, because Nir was making a good point, it's 15, what's the big deal? Well, if the RA pressure is 20, and then you're calculating your TPG, well, you still got a problem, and that's something that you could have predicted beforehand. If this was all so simple, we would have had this figured out a really long time ago, but it's probably worth saying that I think it was Rob Mitchler, maybe in like 1990, documented that one of the biggest problems we had before we had this PGD thing was right-sided heart failure. We're still dealing with it. That was the #1 reason for mortality when transplant took off, and now it's a problem again.
I have one
Getting very short because we time
one
out.
question to U.S. doctors. You have huge experience with Impella and transplantation from Impella. So as a best way to judge the reversibility of PVR, what is your experience with this? Because we transplanted once a year in our institution, but many patients from Impella.
Rachna, you want to take it?
Yeah, we've definitely seen especially with the 5.5s, you see just outstanding unloading of the left ventricle, and as a result, responsiveness. And I think in our experience, those patients have bridged well. So to my point about not having enough patients bridging from VAD, Impella 5.5 is probably, the only device that comes closest to that, to mimicking that experience. So that's at least what we've seen.
One thing I like
Go
to
ahead.
differ on that opinion. So we do a lot of 5.5s, and so many times on the young patient, same thing, pulmonary hypertension and the PVR is a big issue when we are listing for our patient. Because sometimes, as you mentioned in this case, PGD versus there was a component from some PVR. What was your ischemic time? And how was the surgery process itself went through? What was your warm ischemic time? And all this does play a role in those things, and we call it PGD. Now, so because it's unknown. Now, in regards to the 5.5, many times we try to put those young people, pulmonary pressures by the 40s, 50, they come down, but associated with, they have a severe MR. That MR does not come down. With Impella 5.5, we put a 2-month, 3-month out, you walk them, diaries well, milrinone, and those are the patients you think, as soon as you put a LVAD, you can see those, pulmonary pressure comes down. And then we think we should have done this, transplanted. But that's the caveat we have, converting them to the transplant.
So
That's
this was a perfect segue
Yeah.
for the next talk,
Okay.
by the way. So
That's
guys,
great.
thank you very much.
Thank you so much.